Thank you very much for your participation. My name is Dr. Kashish Khan. I'm the pediatric surgeon working in UK. Welcome to another very important session of National Overseas Doctors Family UK, which is in collaboration with the federal government of Pakistan. Today's session is quite important with the aspect that we're going to talk about the pain management in relation to the COVID pandemic. We have got two very renowned and famous speakers with us. Let me introduce you first to one of these speakers. The speaker name is Dr. Shehzad Anwar. He's an international spine and pain medicine physician. He did his post-graduation after doing his MBBS. He did his post-graduation training from Beijing University of TCM. He also did further training from Harvard Medical School in USA, and that further did his master's in medicine from Cardiff University. He has done three fellowships in pain medicine. One is from Hungary, one is from Turkey, and one is from USA. He's also a diplomat of the Medical American Board Academy. So thank you very much, Dr. Shehzad Anwar, for your participation. And our second speaker is Dr. Saeed Mahmood Ali. He has got some computer glitch, which he's trying to sort it out. So hopefully he's going to join us soon. So as soon as he'll join, I will introduce him also. So this is quite an important aspect regarding the pain, because sometimes even I'm a doctor, pediatric surgeon, we do receive quite a lot of children having long-standing chronic pain, and it is so difficult to manage their pain aspect. So I will hand over to Dr. Shehzad Anwar. If you can please start your teaching session, and then we can take it from there. If any of the participants has got any questions after the session, by all means, please write it down in the chat box, and we can answer your questions. So Dr. Shehzad, the mic is yours.
Thank you so very much, Kashif, for the nice introduction, and thank you, NODFA, for organizing this. So, I mean, we can share our experience regarding pain management, and especially pain management during these serious times of COVID pandemic. So let's start. Bismillahirrahmanirrahim. The topic is overview of international pain medicine or the pain management. So before I start, a few questions to audience that what percentage of patients we have who suffer from pain? I mean, because the statistics say that there are the most common reason for any person to visit a patient to a primary, secondary, or tertiary care center in the world is primarily because of pain. There was study conducted which proved the stats that more than 65% of patients who visit tertiary care or primary care centers is primarily because of pain, right? It's such a big problem, but we were, during the medical school, we were never taught pain as a subject. And then even during the post-graduation in any specialty, we were never taught to have a multimodal approach or multidisciplinary approach for chronic pain management. And now the Western medical science has realized that it's just not the biological part. It's not just the biological part. We have also to consider psychological and social aspects. And I usually add that not only psychological and social, but spiritual aspects as well. So we'll discuss briefly about the biopsychosocial model as well. So what is pain? IASP, International Association for Study of Pain, defines pain as an unpleasant sensory and emotional response associated with actual or potential tissue damage or defined in terms of such damage. So it's not purely that a physical damage has to be there. It can be emotional, it can be physical, or it can be an imagination or threat, which can be explained in some terms. So pain, especially chronic pain, is very, very complex. And it's not one modality or one specialty which can treat pain. So we have to combine different modalities. Now coming to types of pain, generally acute pain and chronic pain. Acute pain, we all know, is of sudden onset, is usually the result of a clearly defined cause, such as an injury or trauma. Acute pain resolves with the healing of its underlying cause. Then chronic pain. Chronic pain persists over a longer period of time, minimum 3 months or more, and is resistant to most medical treatments, and it often causes severe problems for the patients. Chronic pain at any given time in different population groups. In young adults or children, it could be, prevalence could be 11% at any given time, and in aged or compromised population, it could be as high as 55% at any given time. Pain represents the most common reason, as I've already discussed, for the patients to seek medical advice or consultation. Many types of pain, including chronic pain, affecting different patient populations, especially the elderly population, children, and the substance abusers, remain undertreated. And also to include in this list is the cancer patients who suffer from cancer pain. And a complete resolution of patient in these categories is rarely achieved. Untreated or undertreated pain has significant physical, psychological, social, and financial consequences. Ask anybody who is a driver by profession and his back or neck pain is not letting him do his business or his duty. So how would they, his family and everybody? Similarly, with all the professions, we have to sit, they have neck problems, they have back problems, knee pain. So any pain which is chronic, I mean, it affects you badly in every aspect, not only the person, but the whole family. Unlike acute nociceptive pain, chronic pain is a pathological state. We know that acute pain is a blessing, and it indicates that there is some pathological process because of that inflammation or trauma or injury. We perceive pain. Once that is solved, the pain goes away. But for chronic pain, this is not the case. It's not like the acute pain. Chronic pain itself is a pathological state associated with functional and structural changes within both peripheral and central nervous system. We'll discuss that in detail. Among these changes, central sensitization and impairment of associated pain inhibitory circuits have been extensively researched. These pathophysiological mechanisms are involved in and at least partially responsible for the development and maintenance of chronic pain states, regardless of their respective underlying etiologies, which could involve neuropathy, which could involve inflammation or tissue damage. So this slide, I want to mention it, that chronic pain involves central sensitization. Central sensitization is amplification, is the amplified pain response, which is body's response to the pain or any a nociceptive or noxious stimulus. In addition to this, body's inhibitory circuits and mechanism, they are also decreased. Because of that, allodynia and all those things which are related with chronic pain or non-specific pain, and they come into play. The three main categories which are, one is neuropathic pain. Neuropathic pain results from nerve damage or dysfunction either in the periphery or in the central nervous system. For example, most common neuropathic pain which the GPs and the people see is diabetic peripheral neuropathy. Then second most common cause is inflammatory or joint related pain. This results from peripheral inflammation or peripheral tissue or joint damage. For example, osteoarthritis or early osteoarthritis, especially when there is swelling and inflammation is more, and then the tissue damage takes over, and so it phases into chronic pain. Then the third is non-inflammatory, non-neuropathic. This is usually also called by functional pain by some people, which results from centrally impaired pain processing, right? So first is the neuropathic pain, in which we have dysfunction or damage of the peripheral or central nervous system, right? So this is chronic neuropathic pain. Then it's the inflammatory or joint related pain, any long-standing osteoarthritis of the knee, lumbar or cervical degenerative osteopathies of the facet joints. All these conditions are the inflammatory or joint-related chronic pain category. And the third, less common but not is, that is a condition like fibromyalgia, where there is impairment of the central pain mechanisms that both involve that center sensitization and inhibition or decrease in the inhibitory pathways which modulate pain and pain perception. Now, talking of chronic low back pain, this may result from many number of causes, which can technically fall into any of these three chronic pain categories. It could be neuropathic pain if there are osteophytes or posterior osteophytes of the vertebral bodies, or there is hypertrophy of the zygapophyseal or facet joint, and they damage the medial branches, which are the sensory branches, and patient usually complain of pain increase with sitting, and then they complain of burning and some paresthesia on their back. So it can have all the components, inflammation of the joint, and then this pain spreads in a way that patient complain of allodynia, that a mild touch can be painful. So chronic low back pain has all these three components. In some patients, they can present with all three different categories. This is a flow diagram. We pain again, acute pain and the chronic pain. Acute pain need to be aggressively treated. It should be, I mean, usually the cascade or the guidelines suggest that we should treat the acute pain as aggressively as possible so that it doesn't enter the chronic phase. If pain persists for more than 3 months, the central nervous system changes, peripheral changes, all those will happen. So we need to focus on acute pain and treat it as aggressively as possible. We should involve physiotherapists and rehab people. We should give the safe and maximum dose of NSAIDs or painkiller. So treat acute pain aggressively. For chronic pain, it can be further subdivided into cancer pain and non-cancer pain. Cancer pain could be of nociceptive type or it could be of neuropathic type. While the non-cancer pain is nociceptive, it could be neuropathic and it could be widespread or functional pain. For chronic pain management, we have to treat it mildly, because usually the population is middle-aged or aged people, and we can't, and usually we put them on conventional medicine for treatment. We don't have to give them so much dose. We have to under-treat it from pharmacological point of view. I will discuss interventional part later on, and that has become so important because giving painkillers for long periods of time and NSAIDs can damage different systems of the body. So again, coming back to acute pain, we need to treat it aggressively. For chronic pain, we need to treat it mildly and involve interventions if required at the earlier stage. Then this is one beautiful article published in 2018. This mentions neuroinflammation and central site sensitization in chronic and widespread pain. This is a beautiful published by British group in Durham, Duke University. This beautiful article, I can share afterward the whole article, that chronic pain is maintained in part by central sensitization of phenomenon of synaptic plasticity and increased neuronal responsiveness in central pain pathways after painful insults, which persist over a time. Accumulated sensitization is also driven by neuroinflammation, that the nerves, they themselves get inflamed in the peripheral and central nervous system both. A characteristic feature of neuroinflammation is the activation of glial cells, such especially microglia and astrocytes in the spinal cord and brain, leading to the release of pro-inflammatory cyto and chemokines. Recent studies suggest that central cytokines and chemokines are powerful neuromodulators and play a sufficient and important role in inducing hyperalgesia and allodynia. After that, if they are injected into the central nervous system, sustained increase in the levels of cytokines and will all lead to all the changes that are related to central sensitization and peripheral sensitization, and even decrease in the inhibitory pathways. So pain continuum, acute pain is normal. This is time limited response to noxious experience, and it's usually less than, it settles in a few days or few weeks time. It is associated with obvious tissue damage. It serves as a protective function, and pain resolves upon healing of the underlying insult of the cause. On the other hand, pain that has persisted beyond normal tissue healing, like the wound or the injury that has settled, but it's still going, it has no protective effect when it's changed into the chronic phase, and it degrades health and dysfunction. Again, you can see that many of the patients suffering from acute pain, if and appropriately, may become chronic pain sufferers, and then it becomes most difficult. Now we come to pain management. Pain management, like any other specialty, involves there was history and examination. If we talk of pain history, we always make a worksheet, and pain itself, pain, where what is the where, which is the site of or place of pain. A is for aggravating factors. I is the intensity. We always use visual analog scale, numeric scale, or the FACES scale in children or aged people who cannot comprehend appropriately. Then N stands for nature. Nature or neutralizing factors. Nature is whether it's dull pain, it's nociceptive pain, it's neuropathic pain. So all these things we have to consider before planning any treatment plan. Then we need to make a diagnosis, acute or chronic,
I think so. We are having some technical, issues regarding hearing Dr. Shazad. Uh, he might have some internet problem. So, Dr. Shazad, can you hear us? Dr. Shazad, I think so. You're on mute. If you can unmute yourself.
Yes. Now you can listen to me. Right? And then we have to determine the underlying cause, if there is any like trauma, cancer, nerve damage, degenerative conditions, autoimmune conditions like ankylosing spondylitis, rheumatoid arthritis, or peripheral neuropathic like diabetic polyneuropathy. Then what are the goals in pain management? Goals in pain management are, first most important thing is we need to involve the patient in decision-making process and then agree on realistic treatment goal before starting the treatment. Take the patient on board, tell him that these are the options, this is what your radiological changes are, and tell them, have realistic treatment goals. Don't tell them, in most of the chronic cases, I never ever, it's been more than 20 years that I'm practicing pain, I never ever tell them that this will go 100%. If we know that this can improve by 80 to 90%, we always tell them it will be 50 to 60%. So patient should hope less and they should get more. If we tell them that this will go away, then they will come back to you, said that 90% is gone, this 10% is there. And then one more important thing is, when you take the history, especially for people who are from our pain fellowship or masters in pain, that note down all the complaints the patient gives you. What happens? Patient comes to you with acute on chronic sciatica or acute sciatica. You treat that patient, pain goes away after a couple of weeks, comes back. Dr. Saab, there is no change in my pain. You ask, what's there? I have pain in my neck. This is actually what happens to us. But when you see the record, that patient comes to you and it complains of backache and radiculopathy. So these are the types. When you jot down everything, you can always show them to do it. Then again, my point is that tell them that it's not gonna go away. We are gonna help you. This will be a good quality pain relief for a reasonably long time. And then what we need to do is we need to optimize pain relief so patient can have improved function and a reasonably good quality of life. And we should also opt for those treatment modalities which have minimum adverse effects. Like we should uh, abstain going for these morphine and morphine narcotic analgesics, because in the elderly population, they have respiratory depression, chronic constipation, so many different things. Rather than going for narcotic and morphine derivatives, these minimally invasive procedures, they are game changers. And then collaborative care is the model. Patient is the ultimate manager because he is the one who has to take care of himself. He is the one who has to take medicine. He is the one who has to come for physiotherapy, rehab, or for an intervention. Then GP and other professionals and the family. So this is a collaborative care. Now, this is one very important aspect is biopsychosocial model. Biopsychosocial model explains that basically it's chronic pain is not just the biological problem. who is suffering from any chronic pain, say a lady who's suffering from migraine pains for last 20, 30 years, and every other day, once or twice a week, has severe headaches, has to go to emergency, get some uh, painkiller injections, IV or intramuscular. How could they be psychologically stable? And then a working person or a young person who is productive and the only earning hand in Pakistan, most of the people are lower middle class, and they suffer from something. So all these aspects. This biopsychosocial model focuses on that we need to involve not only focus on the management of the pain, we also need to involve psychologists, especially who are trained in CBT, cognitive behavioral therapy, because there is level 1 and level 2 published evidence that CBT is so much helpful for chronic pain patient. And then this social aspect, the family, the workplace, all these, it's a collaborative, it's the biopsychosocial model. Look at this picture. Nociception is not always the same as pain. Biopsychosocial model explains that if somebody suffers from any injury or trauma, there are so many different factors which influence that, like beliefs or concerns about pain, psychological factors. Patient already stressed out, anxious, is in anger because of some other factors. Then cultural issues. What are the expectations of the treatment? Then other comorbidities, how he copes with the pain, coping strategies, and then the social factors like family, work, all those things. And then influence of all these factors will determine the pain, right? It's not purely the injury. Different people, I mean, same intensity of trauma in two different people will not result in the same intensity of pain or their response to pain. So these factors, including beliefs, concerns about pain, psychological factors, emotional state, cultural issues, comorbidities, coping strategies, how you cope with it, how strong you are, and then the social factors, how cooperative the family, how supportive the work people are, then this will uh, determine the pain. And the one definition of pain is what the patient says hurts, that must be treated, right? What the patient says hurts, that is pain, and that must be treated. Now we talk briefly about the multidisciplinary pain management. So you can see all these things. We need to have a nice sleep hygiene, lifestyle management. Well, lifestyle management means people who complain of chronic low back pain or neck pain, we should always advise them they should avoid sitting for prolonged hours. Then psychological management, especially cognitive behavioral therapy, physical therapy, rehab, occupational therapy, medicines, interventional pain management, complementary therapies like acupuncture, education, and some clearing some concepts about the pain and all those things. And then finally, relaxation techniques, deep breathing and other things. So this is a multimodal approach that involves pain physician, physiotherapist, rehab, complementary, alternative, occupational, so different things. And pain cannot be treated one single modality, especially the chronic pain. This is one old paper published in 2007 by an Australian group, and this is a beautiful paper. This says that contribution of psychological factors to the development of chronic pain, the key to better outcomes. The study was that those people who were given relaxation techniques, and in those groups where the psychologists were involved, they responded better, and as compared to those patients who were given only the pharmacological treatment. Now, our specialty, that is interventional pain management. What is it? Interventional pain medicine is a super specialty devoted to decrease or eliminate pain with use of minimally invasive and non-invasive techniques. It fills the gap between pharmacological management of pain and more invasive surgical procedures. Usually what was there, the patients were given medicines, NSAIDs, narcotics, all those things. And when they did not respond, they were offered invasive surgical procedures like laminectomies and open discectomies, knee joint replacements, fixations, all those things. Basically, this interventional pain medicine fills this gap between the medicine, and rather in certain cases, this should be the line of first line of treatment in severe or lancinating pain. What we do is we relieve pain by these four mechanisms or four techniques. The first most common technique is interrupting the pain signal along the neuronal pathway. This is done by giving a simple nerve block, right? When we give local anesthetic alone or with mix some steroid, what the local steroid does is paralyzes the sodium channel, so it interrupts the pain signal, and then it has anti-inflammatory effect, and the pain goes away in the patient. So the second is remodeling anatomical source of pain, that is neuromodulation. This is relatively a new technique, and especially central pain with radiculopathies. In those pain, what we do is we insert or our cannula, that is radio frequency cannula, in the foramen where the dorsal root ganglion is, and in the vicinity of the dorsal, in close proximity of the dorsal root ganglion, we give large doses of radio frequency energy at a low temperature at around 42 Celsius for 6 to 8 minutes, or even certain studies say do it for 20 minutes, but usually the consensus is about 6 to 8 minutes. What it does, it remodels the source of pain, the sensitization or that amplification that reverses, that gets modulated, and patient gets long-term relief. Then we use neuro-augmentation techniques like spinal cord stimulation, peripheral nerve stimulation, and then for cancer pain especially and terminal palliative care, we can implant implantable drug delivery systems. So four basic path mechanism: interrupting the pain signal, that is nerve blocks, then remodeling is neuromodulation, neuroaugmentation with spinal cords and peripheral nerve stimulators, and implantable drug delivery systems. We can treat all the conditions. So every pain, whether it's cancer, it's non-cancer, it's headache, it's toe pain, it's cervicogenic, it's autonomically mediated, CRPS, name any pain, we can help patients with minimally invasive procedures and non-invasive procedures. Some basic techniques include dry needling, trigger point injections, facet joint blocks, diagnostic nerve blocks, selective nerve root blocks, SI joint injections, sympathetic like stellate, lumbar sympathetic, celiac plexus blocks, all those. Trigeminal is one of the worst pains to have. The strong evidence is for even in patients who have gone microvascular decompression, they still come back with pain. Then we perform a procedure, is radiofrequency rhizotomy through foramen ovale. We reach the Meckel's cave, and we can selectively stimulate the affected branch V1, V2, V3, and then we can ablate it at low temperatures like 60 degree, 50 degree, and 60 degree, 60 seconds each. Or we can do the pulsed RF neuromodulation. Both have now reasonably good evidence is there for pulsed RF neuromodulation as well, but the stronger evidence is for thermal RF. Then stenopalatine for cluster headaches or atypical facial pain. Then for facet arthropathy or mechanical back pain, we can perform radiofrequency neurotomies of the medial branches. For patients who are very obese and who are unfit for surgery, or even younger patients below 50 who have a severe pain and don't respond, we can perform genicular infrapatellar saphenous nerve, radiofrequency neurotomy, which are the sensory branches to the nerve. And so different techniques and different procedures, we can treat both non-specific
I think so. There is still a problem regarding the internet connection.
techniques which are performed for chronic pain or even in patients who have failed back surgeries, and there 30% incidence of pain in after knee replacement world over. In those cases, this radiofrequency rhizotomy of geniculate nerves has a lot of role to play. Coming to conclusion, chronic pain is a very, very complex disease and it's not a symptom. Multi-modal and multidisciplinary approach, including interventional pain procedures, should be considered with every pain condition. It may work in situations where all other options don't work. Pain is most effectively treated with a multi-modal approach. We should utilize all resources that are available. Thank you so very much. If there are any questions, we can have this after the second.
Thank you very much, Dr. Shahzad. That was a very impressive presentation, I must say. I myself learned a lot, and I think so it will really help me treating my patients with a chronic pain, that how to deal with them. So thank you very much for a very in-depth presentation and how to deal with those kind of neuropathic pain, neurogenic pains, and other pain pathways, which was really good. The good thing is that we have got our next speaker, Dr. Saeed Mahmood Ali. Let me introduce you to him. He's the head of department of pain medicine in Sheikh Zayed Hospital, Lahore. He has done his MSc in pain medicine, and also he has done his fellowship in interventional pain practice from USA. Dr. Saeed Mahmood Ali, thank you very much for your participation and being a part of it. So the mic is yours, and just teach us and educate us. Thank you very much.
Thank you so much, Dr. Kashif and Dr. Shahzad for giving me the opportunity. I am very thankful and grateful to all of you. Can you hear me?
Yes, we can hear you now.
Thank you so much. Thank you so much, Dr. Kashif and Dr. Shahzad Anwar, to give me opportunity to learn as to share the experience about the pain medicine. Very well presentation by Dr. Shahzad Anwar about the pain, especially acute and chronic pain management. And my presentation going to be a very simple because of Dr. Shahzad Anwar, as he has completed major portion of the chronic pain management, and we discuss about the specifically to the chronic pain management in COVID pandemic. Because of the COVID pandemic, all over the world things are changed drastically, and not only the industrial area, health system, schooling system, everything is going to be changed, and it's going to be very challenging. And definitely with the passage of time, we are learning how to improve the system and to save ourselves, our family members, and to the patients, and to the society as well. Chronic pain, as described by Dr. Shahzad Anwar, is a treatable condition all over the world, and because of these causes suffering, limited daily activities, and reduce the quality of life. If we talk about the chronic pain, basically quality of life affect a lot, and our limited daily activities are limited. I was reading a daily burden of disease about this. About it costs around 100 billion for per annum for these chronic pain, and for all, if you talk about the back pain, it costs around the 80 billion per annum. So pain is at the top. People need medical care. Chronic pain condition rank third of the top 4 leading cause of years lost to disability, including back pain, general musculoskeletal disorder, and neck pain. Everybody afraid of disability. They want to be a part of the system. They want to be part of the society. So chronic pain affect directly and indirectly. So disability worldwide is associated with multiple psychiatric comorbidities and the opioid crisis. Why opioid crisis? If we talk about the chronic pain, and definitely as acute pain, but chronic pain plays, opioids play a vital role in these things. And you know, in Asia is one of the most top of the country who produce opioid, and unfortunately, often less than 2 or 3% is provided by to these countries, rest of the world by the developed countries. So they are suffering. Chronic pain की हमने बात की, basically जैसा Dr. Shahzad said, it's a fundamental human right. Everybody should be treated. Either it's a cancer pain, it's a chronic pain, it's pandemic, whatever it is, it's the fundamental human right to be pain free, and he can take care of himself, to his relatives, with the family members and society, and he can contribute so that he can contribute. Pain is the fifth vital sign. We have to look at very seriously because it affects all the system. And if we say in the COVID pandemic, pain, chronic pain can lead to immunosuppression. That can lead to increased morbidity and mortality. So we have to control it. Most of the patient, if you're going to a symptom of the patients like COVID, myalgias, and they are not responding to conventional regimes, rather they have to be on the opioids so that they can be pain free and they can work better. If you talk about the coronavirus is basically a large family of respiratory viruses known to cause illness ranging from common cold to more severe illness, such as Middle East respiratory syndrome and severe acute respiratory syndrome. The current outbreak has been caused by a sustained strain of coronavirus that had not previously detected anywhere in the world before the outbreak was reported in Wuhan, China in December 2019. Pandemic, an epidemic occurring worldwide or over a wide area crossing international boundaries and usually affecting a large number of people. The classical definition includes nothing about the population immunity, virology, or disease severity. It's an ongoing pandemic that causes severe acute respiratory syndrome, resulting in systemic complication and death. Till now, it's about 1 million cases reported, and out of those, 2.5 million deaths. So that's alarming. How it impact of COVID-19? What's it called? Health, medical resources. What happened in 2020? What about the resources? People not expecting that these things will happen. So they're exhausted their medical resources. They lost their health professionals. They lost their front lines. Doctors were in the battle without the resources, without their gadgets, without their arms. Lot of doctors lost their lives. What is the responsibility to limit the spread? Patients who need an urgent care. What about the life-saving therapeutic interventions? So these are going to be a very challenging, still they are, and what we have to do. As his responsibility as a pain physician, we have to care for our own health, care of your family members, care of the societies, care for non-physician healthcare provider, and also for the balancing patient rights for treatment, benefit inherent in the treatment of pain. So it's going to be very difficult. So what to do in COVID pandemic? Specific impact of COVID-19, change of priority of health workers. utilization of available resources because it's going to be exhausted, limit the spread of infection, therapeutic intervention and patient visits, non-emergency chronic pain management procedures, and the telemedicine. So these are the specific impact of the COVID-19. COVID coronavirus teach us how to live with these pandemics, to stay at home and to treat your patient, to save yourself, to your family members and the others. So these are the things. Priorities, WHO guidelines for elective and non-emergency surgery should be postponed, and only for the emergency surgeries you should be proceed. And with all the preventive measures you have to take so that you can be protected. Chronic pain patients are at risk. Why they are at risk? Because we have Dr. Shahzad and Varia discussed, because of the psychosocial model here. Patients usually are chronic pain patients usually are depressed, they are handicapped, and because of the COVID, they are isolated. There is financial crisis, drug continuity treatment, they can't go outside, people afraid to meet each other, and we have to maintain a social distance. So chronic pain patients are at very risk. What to do, how to manage their patient? So this is going to be very challenging. Practical suggestions: we have to be safe for ourselves, for our family, our kids, parents, our patients, for the society. Telemedicines play a pivotal role. The use of social media, you are just a call away from, you can use, like we are using Zoom, WhatsApp, and other medias are available. If we talk about the COVID-19 pandemic has brought unforeseen issues in the field of chronic pain. Shelter in place and social distancing are two of the best way to limit the spread of infectious respiratory disease. But because of a health professional, we have to see the patient, we need history, sometimes we have to go for examination. And if we talk about the chronic pain, sometimes we have to give a diagnostic block, because without these things it's going to be very difficult to manage. Opioids, it's going to be limited available, you have to prescribe with this prescribed drug, so you need under the supervision. Protection oneself meal, protection others, because one's own safety depend upon the safety of the whole community. So because these things can be very problematic, so people are develop protective gadgets, they are limiting. I said they are using the telemedicine on phone calls and messages, and if we have to meet them, we have to use the specific protective measures. We have to use goggles, we have to use shields, gloves, protective equipment. All things should be there so that you should be safe. Biopsychosocial model, continuity of care and medication, because as we have discussed, this the post-COVID syndrome. If we talk about the post-COVID syndrome, after the pain, the other problem is psychologically. They are depressed, they are schizophrenic, they are in anxiety, they have generalized body aches, the pains, they are not responding to conventional regime. And what about the care? We have to continue their medications. They should be physically rehabilitated, they should be psychologically supported. Without these, it's going to be very difficult. In this era of telehealth, it is more important than ever to provide patients with education about their condition and management options involved in shared decision-making process. What they want to do, what's their breakthrough pain. Either they have to increase their dose or shorter the duration, or we have to add a combination of drugs. Is there going to be any side effect? What's that? So we have to, with this new era, social our apps are creating, they are very supportive so that we can manage their patient from a far distance away. Telemedicine can help us to provide ongoing service to patient. It includes assessment, our effective treatment is effective or not. We need to do something more. We need to discuss this thing or continue the treatment, or we have to modify the thing. And the patients who are giving emergency treatment like rescue maneuvers for the like cancer patient or some pathectomies, so we can follow up on your telemedicine. So these are the drastic changes in a couple of years that COVID has teach us how to do on a one place to far away. Evidence is promising for the use of telemedicine in the follow-up of chronic pain patients. COVID-19 is having a profound effect on healthcare and patients with pain. Delaying or stopping treatment for patients who are suffering from severe chronic pain will have negative consequences of patient, including increase in pain, disability, depression, and poor quality of life. If we delay or we stop the treatment of the cancer patient, they are more, their quality of life, they are just, we want to, for the palliative care of life, they are depressed, they have suicidal thought. We have to give them pain-free so that let them go peacefully. This can have significant downstream effect, including worsened mental health and addiction disorder, as well as increased future healthcare spending. And that's all. Thank you so much for my.
Thank you very much, Dr. Mahmood Shah. Again, that was quite an impressive presentation. I'll tell you, if you can stop sharing your slides. Yeah, and I'll just wait for, yeah, you've got a small icon at the top of your screen which says stop sharing. Yeah. Yeah, thank you very much. Yeah, thanks. Dr. Mahmood Shah, very impressive. The way you explained the COVID-19 role and pandemic role in the treatment of the chronic pain as well as the acute pain, and what measures needs to be taken. That is quite impressive. Thank you very much for that. Now I received quite a few questions, and we are also running short of time also, but these are quite an important questions, and I think so it's important for me to ask those questions because the participants are very eager and they really enjoyed your talk. So can I ask the first question from Dr. Shehzad Anwar, please? The question is that, is pain medicine a subspecialty of anesthesia?
Thank you so much, Dr. Kashif, and to the Dr. Shehzad Anwar. I believe one thing, it's pain for all. It's a multidisciplinary. It's not to the specific field. It's for the all. It's for the neurophysician. It's for the radiologist. It's for the orthopedic surgeon. The aim is to keep the patient pain free. As I said, it's a fundamental human right, and everybody should treat the patient according to this. So it's not specific to any field, to my opinion. Everybody should manage the patient, and they all already doing. If we start from the general physician, they are managing the pain. The orthopedic, they are already doing the pain management. So this is the field that has overlapping, and everybody is managing the patient, and this is what the aim is, to control the pain, so that the patient should back to their life, the quality, disability should be decreased.
Thank you very much for very nice answer of that question, which has also increased my knowledge also, because usually for the chronic pain management in the hospital is the anesthetic department which deals with it. But I can even educate them that there is other aspect of the cloud also. My second question, which is asked from one of the participants from Pakistan, and either of you can answer it, whether Dr. Shehzad can answer it or you can. The other, what are requirements of entering the pain medicine training program or fellowship?
I think the best answer is given by the Dr. Shahzad and what
So,
already he is doing.
right. Thank you so much, Shaji. Thank you so much, Dr. Mahmood, for a wonderful presentation. Really learned so much. Thank you. Regarding the pain management training, primarily now there is second fellowship by CPSP. It's a 2-year second fellowship, but the problem is that they have allowed only the anesthetist to go for second fellowship. In the other parts of the world, it's not only it's not the subspecialty of anesthesia. If we talk of USA, the people from PMR, physical medicine, rehab, anesthesia, neurology, orthopedics, general surgery, neurosurgeons, neurophysicians, so many people coming from different backgrounds. So that this is an evolving field. And next few coming years, this would be the biggest specialty because the stats say more than 60% of patients who visit any health facilities is primarily because of pain. Regarding the programs here, we are offering two types of program. One is the MSc pain medicine. For that, the basic criteria is you just have to be an MBBS doctor, you need to be a medical graduate, and you have done your house job. But we only at present we are offering that only from Rifa University. We have only 20 seats approved by PMC. We are trying to get it into the other universities like RMU, Rawalpindi Medical University, University of Lahore, Superior University, and inshallah we will soon be launching our program from Superior University in March. So for that, regarding the fellowship in interventional pain medicine, Society for Interventional Pain Medicine, SIPM, is already offering fellowship program that is skill-based, hands-on training program based on 8 modules. For that, you need, it's because it's a supra specialty. The minimum requirement for that, either you have already done your MSc pain medicine, or you have done your fellowship or MCPS in any specialty, then you can enter for that specialty. Thank you.
Thank you very much, Dr. Shahzad. That's a very in-depth answer and the knowledge for how they can go for the postgraduate or the fellowship program in pain management. And I think so it is one of a very important emerging field in the medicine. And I do recommend people who are interested to go for the fellowship because there are increased numbers of patients with an acute and a chronic pain, especially during the this pandemic, which comes to the next question. And the question is that COVID pandemic has affected us all. How are pain specialists coping with this?
Thank you so much, Dr. Kashif. Definitely, COVID has affected all the healthcare workers all over the world, including they lost their life and they are fighting without the exhausted resources. Same with our system, we have to close our OPDs for elective theaters and emergencies, and we only deal with the emergency services. And that is again with a very challenging because of our own safety. We can be a carrier, we can spread the infection to our family members, to the society, and to the patient as well. So what we are doing, we have to go for the tests, some investigation, X-ray, some COVID test, and we are doing with the protective equipment. The personal protective equipment is compulsory for all of us. We are using with the shield, goggles, and these things. Although it's affect all, including the health, financial, and the society as well. So but for the patient who can be dependent on the pain management, so that they can back to their life, we have to go for this thing, and its impact is directly proportional to their treatment over there.
Thank you very much for that, answer of that, very important and specific question. and which leads me to the same, related question which you have just answered, that how can patients manage their pain during the pandemic? Do they have to take any kind of extra special precautions, any medications or everything, especially those patients who are suspectable or have COVID-19 symptoms?
Thank you so much, Dr. Kashif. Actually, and again said, because of the technology, things are and we have learned how to use this technology. Telemedicine, or everyone is going towards the telemedicine. The patient having the problem, he can discuss, we can have video chat, he can send his uh, movie pictures, what's the problem, either he's in gate or where the site of the location. Number two, everybody we is trying to for conservative management. Usually on the tablets, if I will talk about the COVID-19 patients, usually they have severe myalgias, they have severe pain, and if they're already existing with some sort of patient problems like cancer pain, that is worsen. They have severe intractable patient, and I have received calls. The patient want to say, "This I want to just suicide." It's unbearable, and the attendant said we can't hear, it cries. So it's going to be very difficult. We try to them on the conventional pharmacological regimes with the combination of drugs so that the patient can be managed. If it's not treatable, if it's not under control, then definitely we have to go to the WHO step letter 4, that is the intervention. If we fail to manage the patient, then we have to go for the intervention.
Thank you very much, Dr. Mahmood Shah. I've got quite a few more questions, but I will send those questions to you through an email so that you can answer them, which leads to me my last question. And I'll see that if Dr. Shehzad Anwar can answer that, question, which says, have you seen any rise in number of patients suffering from chronic pain during pandemic? So, Dr. Shahzad, if you can give your opinion on that.
Yes, thank you so very much, Kashif, for this question. Definitely, we have seen the rise in number of patients who were suffering from pain. The intensity of pain has increased because of the psychological and social factors. But talking of OPD numbers, they have definitely gone down because the government policy is generally to many of the centers were converted purely COVID hospitals and all the cold cases. But if we talk from population point of view, definitely the stress factors, the emotional stress, the financial stress, and get to the isolation, all these things, they worsen the pain, both the intensity and the incidence of pain has increased remarkably. Some few studies published by US people that show that the chronic pain was especially non-specific by 13% in New York and New Jersey states in people over 60 years of age. So that one study, but still there are other studies being done. This proves that the incidence of chronic pain has got worse of the COVID pandemic. And in addition to this, there were non-availability of the pain clinics. Gold cases were not being treated appropriately. So that is another factor that has that for this rise of chronic pain patients.
Thank you very much, Dr. Shahzad and Dr. Mahmood, which bring us to the end of our very important teaching session on uh, acute and chronic pain in relation to the COVID. On the behalf of National Overseas Doctors Family UK, and also on the behalf of the federal government of Pakistan, who are doing the Yaran Watan program, I'm really grateful to Dr. Shahzad Anwar and Dr. Mahmood Shah for giving their valuable time. Still, I've got about 7 or 8 questions which needs to be answered, but we are running short of time, so I have to wrap it up. But as far as I am concerned, that was a very, very informative session. It is a bit different than the other medical sessions which NODFA has arranged. Pain is always an extremely important, whether you are doing any kind of surgical intervention or whether you are dealing with a medical patient who doesn't need any kind of surgical intervention. Pain is the key factor which make them better. And I think so you both are doing an amazing job in treating those patients and controlling those pains and giving your expertise. I don't think so that without the pain management, the patients will improve completely. So thank you very much, both of you, again for a very nice session. And hopefully we will request you again to come in our next session and further educate us regarding the pain management and everything. And I'm also very grateful to the participants who just with us and attended the whole session and listened to each and everything what our panel has said. If they want to re-listen to it again, it will be present on the Facebook, which is our NODFA Facebook, which is National Overseas Doctors Family Facebook, and also on the federal government website, Yaran Watan, and also on the YouTube channels also. So once again, thank you very much, everyone, for their participation and their time. Inshallah, we will see you again. Allah Hafiz.
Thank you so much. Thank you.